First of all, I welcome for the today's Blood and Organ Donation Committee CME-6, the State President Dr. B. Sridhar sir for this program. I welcome Dr. P. Sengutuvan sir, the immediate past State President sir. I welcome Dr. S.S. Sukumar sir, the Advisor Blood and Organ Donation Committee. I welcome Dr. A.K. Ravikumar sir, the State President-elect 2026. And I welcome Dr. NRTR THIAGARAJAN sir, the President-elect 2027. I welcome Dr. M. Dravya Mohan sir, the Honorary State Secretary, IMA-TNSB. And I welcome Dr. D. Solomon Jaya sir, the State Finance Secretary. At the same time, I welcome the speakers of the day, Dr. R. JAYAPAL, from Ramakrishna Hospital, Senior Consultant Surgeon in the Hepatobiliary Tract, and Dr. S. THIAGARAJAMURTHY, the Chief Cardiothoracic Surgeon. And I welcome Dr. DEEPA Bentley, the Director and Professor of the Institute of Anatomy, Madras Medical College. This Blood and Organ Donation Committee, CME, every month we are conducting, this month being the 6th meeting. In this meeting, we usually play this video about the family security scheme that I thought of putting it in our meeting so that people who are not seen this video can go through this video and become a member of the family security scheme. I think we can follow this in all of these Zoom meetings which are being conducted by our Tamil Nadu IMA-TNSB and also in all the IMA branches meeting also, so that it will be an eye-opener for all the people to actively take part in becoming the member of the family security scheme. Those who are not become FSS members, please join the participants today. I request the people who are eligible up to 55 years can join this program. Please become a member in FSS1 and FSS2 so that your family will be benefited. This is our Blood and Organ Donation Committee, and then our emblem and all those things. This is the badges, the two badges which we have issued, and the same badges we have sent it to all the branch office bearers also. And if anyone need more of the badges, the cost of the badge, each badge is ₹25 per badge. And these are all the two badges which were released recently in the State Council meeting at the Chennai. It is one in the about the blood donation and another one about the skin donation. தானத்தில் சிறந்தது ரத்த தானம் செய்வோம். And here it is this donate this your skin, save a burn victim. This the badge cost of the badge is 25 per badge. I invite all the branch office bearers to purchase this badge and keep it in your branch. At least each branch, at least one badge, at least you keep it in your branch so that it will be useful for the people to educate about the eye donation and the skin donation. And this is the badge which was released at the recently conducted meeting. And two sets of other badges also. One in English, it is the donate blood, and another one is about the Tamil Tol Danam, Uyir Danam. This is also a very nice badge, which also I am thinking in terms of promoting it, and I have asked them to prepare, and I bought on my own, and I am keeping with me, and I wanted to wear the badges. Usually I used to carry these badges wherever I go. I used to wear badges. At least our organ donation committee people at least should wear the badges so that we can educate the people. ஒரு ஃபங்க்ஷன் என்னுடைய பேத்திக்கு வந்து காது குத்து நடந்தது. அந்த ஃபங்க்ஷனில் கூட பேட்ச் குத்திட்டு இருந்தேன்னா, டாக்டர் இங்கே கூட நீங்கள் இந்த பேட்சை குத்திட்டு இருக்கிறீங்களா அப்படின்னு சொல்லி தே ஆஸ்ட் லைக் தட். ஸோ இட் ஹேப்பன் லைக் தட். So, regarding the communication about the meet, our state office is already doing, and then I request all the IMA branches to spread the message about the program to all the branch members so that they can join in larger numbers. And I request all the branch people to conduct the CMEs about the blood and organ donation committee periodically. This month being the World Blood Donation Day on 14th June, I request all of you to please conduct at least one meeting about the blood donation and organ donation, and then send the photographs and the report about that. And we are planning to start the IMA blood bank in some of the branches. Some of the branches like Trichy, Erode, Salem, and Pattukotai are willing to start the blood banks, and we are encouraging them to at least to each zone, at least we like to have at least one blood bank. The blood donation activities, I request all the branch people to conduct at least one blood donation camp once in 2 months or once in 3 months at least, so that we can have at least 8 to 9 4 to 5 blood donation camps, so that we can collect more units of blood. And blood donation awards are there in the national and the state level. I request all the office bearers who are interested to get the recognition for their branches to please do the activity and get the awards. And blood donation activities, you send the reports to my number and also the IMA Tamil Nadu state office address. And these are all the meetings every month we are conducting: January, February, March, April, and May. Last month we have conducted about the brain death and organ retrieval. And here in June 2026, we are going to conduct a meeting about the liver, the heart donation, and also about the body donation, what they are doing in Madras Medical College. And monthly meeting we are conducting as in the last Tuesday. And regarding the eye donation, we are thinking in terms of the eye retrieval centers, which we are going to plan along with the AMS chapter. We call it as the Kannuli Danam. The organ donation awareness meeting we are going to conduct in all the medical colleges, at least we will start, and also in the colleges mainly, so that more people will be educated and more people will be started registering. These are all the handouts, English and in Tamil, which we have created. I request all the branch office bearers to take this as a copy and then print the organ donation handouts and issue to the public. And to increase the awareness, if a person with the brain death donates the organ, the local IMA branch office bearers, I request them to go and meet the relatives during funeral or their home and then thank them by giving a citation. And in IMA meetings, 5 minutes you people please spend to spread about the message. And the organ donation workshop also we are thinking in terms, and we want to have more of the people to join in these activities. And the hospital coordination meet also we are planning. And the main thing is the TRANSTAN. I request all of you to go to the TRANSTAN website and become a donor to register. If people are interested, this is the donor card which is being issued first. And this is the method of downloading the card. Every time I am telling, this is the TRANSTAN. If you go to there, and automatically you can download the card by going through the steps which are there, which is already published in our state council meeting book also, and also in the IMA time of bulletin also. This is the latest card, organ donation pledge certificate they are issuing from the headquarters. And these are all the awards which are there in our branch. And the skin donation, skin retrieval center, the skin donation, the Sivagasi branch is planning to have the skin bank and skin retrieval center, and it is under discussion. And this is about the blood donation. This month, the World Blood Donation Day, I have donated blood. Like that, I request all the doctors who are interested to donate blood. Actually, we have an award for the maximum number of the units donated by doctors in their branches will get the first prize and second prize, like that, in the state TIMA conference. So I request all of you to become those who are willing to donate the blood. And these are all some of the blood donation activities which are happening. The Erode branch is doing more of the activities. They have already collected around this month also in June till June. There are about in the app from May onwards, they have collected around 150 to 200 units. This is one camp on 22/6. Another camp on 21/6, 15 units. Another camp on 21/6 by Erode for 60 units. And on 13 and 14 for the World Blood Donation Day, Coimbatore donated around 142 units in a Kikani school, NGP college, and then Lee Meridian, and in Hafisa Hospital, they have donated 142 units. And these are all about activities which in Chennai, there was a blood donation camp which was conducted. In that, the Vice President of the North Zone, Dr. Bhubadi John, is attending. And there, around 58 units of the blood is being donated. And Erode, once again, blood donation camp. And in Pattukotai also, there was a blood donation camp which was conducted. And there, they have donated 15 units of the blood. And they are trying to get a IMA blood bank also. They are telling about that. And regarding the skin donation in Ganga Hospital, Coimbatore, they are doing it. There are about 5 skin donations happened this month. That's happening. And one more concept is the non-transplant organ retrieval center. That is the thing which we have to create for all the hospitals. Those are all the hospitals which are having the ICU facilities and more than 25 beds can get approval from the state to become the non-transplant organ retrieval center. That they can do it. And they can, if they certify death in their brain death in their institute, they can be one of the part of the organ retrieval team. And organ donation activity happened in Coimbatore in KMCH hospital on 6th of the June, and where one young boy from Dindigul has donated the organs. And this is about the TRANSTAN waiting list. If you can go to the TRANSTAN website and see and all these things. I request all of you to do, and even the transplant in the Chief Minister scheme also, they are giving a maximum 22 lakhs for the transplant for the liver and other organs. Those who are having doubts, please call me and ask me. I wanted to mention an important thing which happened this month. The body donation, which was done by the Erode IMA past president, Dr. S.T. Prasad. This is what happened, and he was suffering from the malignancy, the blood malignancy, and he wanted to, at the, in the deathbed, he wanted to donate the organs to the body donation activity, and so it has happened like that. And his body was donated to the Perundurai Medical College. That's what happened. And all the doctors which were assembling together, they were going, that they have recorded and they have shown in the YouTube also. That's what they have done. I wanted to show it in this forum so that our members know about the body donation importance, how our doctors also are ready to donate the body for the education. So that's what happened. So another thing is that like this, the video clippings, request all the branch office bearers to create awareness about video clippings and celebrities. We can send messages about this in our WhatsApp groups. Not only sending the political messages and all those things, we need to send messages about the video clippings and what are all the things happening, what are all the things we have done as an IMA member and all these things, and also awareness badges we need to send to the people. That's what. Thank you. Now I invite our state president, Dr. Sridhar sir, to give the felicitations and inauguration of the program.
Good afternoon, everybody. Thanks for calling me, Dr. Rajesh. And
Yes, sir. Welcome, sir.
the recording, impressive record of body, blood, and organ donations. Special mention about Dr. Prasad, who had been very close to me, even when I was not a big office bearer. He was very close to me, and he helped me in my daughter's matter when I wanted a help from Erode Corporation. He did it in a couple of days and got it done, paying money, his money, and refused to take it back from me. Such is the magnanimity of that individual, and the ultimate magnanimity has come by his gesture of donating his own body for the education of his fellow younger students. And that is the real spirit of the medical profession. He has shown that, and he has shown that actually there is a Tamil proverb, "Irandalum ayiram pon, irundalum ayiram pon." They used to say that for elephants, because they are worth that money in gold even if they are dead, meaning the cost of the tusk. Here, this gentleman has been worth as a gentleman even when he was alive and even after his death. He has proved to be a gentleman with maximum ethical practice and a wonderful human being. So this is the message of the day, and we are here to listen to some excellent topics to be delivered in the coming session. I wish the speakers well. I thank them for sparing their time for the program. I congratulate Rajesh Babu for arranging such a program and wish the delegates will learn a lot about body and blood donation and skin donation through attending this program. Thank you, and over to you, Dr. Rajesh.
Thank you, President sir, for your nice words and felicitation. Now I invite Dr. P. Sengutuvan sir, the immediate past state president, to give the felicitations.
Thank you, Dr. Rajesh. I am really very glad that you focused Dr. Prasad's video at the Erode IMA's contribution to the blood and organ donation. This is a major achievement. It should be appreciated, and you have crossed the milestones in promoting the blood and organ donations. My hearty congratulations to you and your team. Respected President Sridhar, Secretary Dr. Dravya Mohan, Treasurer Solomon Jaya, Blood and Organ Donation Advisor Dr. S.S. Sukumar, Chairman Dr. Rajesh Babu, and his team, and speakers of the day. I'm really very glad to be one of the members to be participating in the programs. I think we can promote many non-IMA members are attending this program. They can be admitted. I advise all the members, non-IMA members who are attending this Zoom meeting, please enroll yourself to the IMA so that the strength of the IMA will be more. Thank you. Over to Rajesh Babu.
Thank you, Sengutuvan sir. Now I invite Dr. S.S. Sukumar sir, the advisor, Blood and Organ Donation Committee, to give his felicitations.
Dear respect President sir, President IPP, President-elect, and Dr. Rajesh, and Secretary and others, sir. It's really very nice that Rajesh is conducting very nice programs every month. Such an interesting person. He's in the meeting, he was wearing 4 badges in his shirt during the state council meeting. He really a dedicated man. And he told about Dr. Prasad, he was a very dedicated person. On the deathbed, since he took a paper and wrote it to his wife, donate my body to the government medical college. It was a great thing that he knew that he's going to die. At that time, he just wrote it and gave it to his wife, who was taking treatment for blood cancer, and he was all right. He was doing a nice job. He was also instrumental in conducting a hospital during COVID time, and he collected so much of money for AIM also. Such a nice person, such an enthusiastic. He was also the assistant secretary of our state long back. So really it's great. And regarding the body donation, it was really great. So many, he showed the video. Dr. Rajesh showed the video. So many cars went and donated the body to the Erode Perundre Medical College. Really great. And I congratulate everybody who is taking part in this because it's a very nice program. For 40,000 people are there. At least 199 people have joined. I feel that more people will join in this program. Thank you, Dr. Rajesh, and thank you for the speakers going to talk. Thank you.
Now, thank you, Dr. Sukumar sir. Now I invite Dr. A.K. Ravikumar sir, the State President-elect 2026, to give his felicitations for our program.
Thank you, Dr. Rajesh, for inviting me. It's really a wonderful program you are doing. The activities which you showed is really amazing. You have done so many activities and you have created awareness. And only my request is these awareness should be publicized. It must go into the social media so that the public will understand that such activities are going on in the Indian Medical Association. And the doctors are not only for their own things, they also help the public and create awareness to the public. And I am proud to say that the organ donation chairman, Dr. Sukumar, he himself is a great donor. He has donated blood every month. Every 3 months, he used to donate blood since his college days. And until he was not allowed to donate, he has been donating more than, I think, 300 and something, 400 units or so he has donated. Hats off you to sir.
Sir,
and another thing is
President elect sir 192 தான் சார். அதுக்கு மேல டொனேட் பண்ண முடியும். எவ்ரி 3 மந்த்ஸ்னா 19 வயசுல இருந்து 66 வயசு வரைக்கும் 192 தான் கொடுப்பாங்க. அப்புறம் கையெழுத்து கொடுத்து வராதேட்டாங்க.
நீங்க எவ்வளவு கொடுத்தீங்க? 200
192. அதுக்கு அப்புறம் வராதேட்டாங்க.
We has done it.
அவ்வளவுதான்
So
சார்.
very nice. Hats off to you, sir, for being an example for most of us. And Dr. Rajesh Babu, I am proud to say that he has already registered in our Coimbatore that his body and his wife's body will be donated. So it's a great forerunners. And today's programs are very interesting. And appreciations to Dr. Prasad. He is an eye-opener for most of us. And he has donated his body in his deathbed. So it is a great encouragement to all of us. And I take this opportunity with the permission of the President to say that recently many incidences has been happening across the state, the violence against the hospitals and the doctors. My message is Indian Medical Association is the political face of the healthcare professionals. Please remember this. Indian Medical Association is the political face of the healthcare professionals. We will be having so much of professional associations, but IMA is the political body. And I am happy and proud to say that with the intervention of the IMA, local branch, Government Doctors Association, state IMA, the problem which arose in Sivagasi was controlled. Actually, that was a big problem, and the hospital was garrowed, and they were asked to pay nearly 50 lakhs to 1 crore for the death which has happened, which was not in the hands of the doctors at all. It was the pulmonary embolism which can occur for anybody, and they don't want to take the body for postmortem. Even the officials were sidelined towards the public. And with the intervention of the Indian Medical Association, the entire thing was brought under control. And the message which I just wanted to tell all of you, because many of you have joined here, you may not be aware of such things. Indian Medical Association is there to protect you. Don't hesitate to call Indian Medical Association in dire necessity. Thank you. I wish the program a great success.
Thank you, Dr. Ravikumar sir, for giving felicitations for our program and briefing about the incidents. Now I invite Dr. NRTR Tyagarajan sir, the President-elect 2027. Sir is not there, I think. Now I invite our State Honorary Secretary, Dr. Deraveya Mogan sir, to give the felicitations.
Respected President, the leaders, first of all, I thank the blood and organ donation for giving me opportunity to be part of this program. I don't want to take much of a time because today's CME on liver and heart donations will enhance understanding, help us contribute more effectively to the life-saving mission. I once again congratulate and thank the speakers for coming and they're going to speak on the topic liver transplantation in India. Where do we stand? The ultimate gift, the long-term realities in heart and lung transplantation and whole body donation. So these are all very interesting topic, and let us go straight into the topic. And once again, thank Rajesh Babu sir for giving this opportunity. Thank you, sir.
Thank you, Secretary Sir, for giving felicitations to the program. Now I invite Dr. D. Solomon Jaya Sir, the Honorary State Finance Secretary, to give the felicitations.
Respected President Dr. Sridhar Sir, Secretary Dr. Thiravi Mohan, Past President Dr. Sengutan Sir, President-elect Dr. A.K. Ravikumar Sir, and the Organ Donation Committee Chairman Dr. Rajesh Babu Sir, and Advisor Dr. Sukumar Sir, faculties and delegates, a warm greetings to all. The volume of work, the way the Organ Donation Committee Chairman presented, the work he has done in the past few months shows the volume of work the team is doing, the great work, and admire his work. And I commend the entire team for the awareness program and for bringing in the relevant scientific program to make the organ donation a reality. Wish the CME a grand success. Thank you.
Thank you, Dr. Solomon Jaya Sir, for giving a nice lecture, the felicitations. Now I invite the speaker straight away. We will go to the topics. And the first topic will be on liver transplantation in India. Where do we stand? By Dr. R. Jayapal, the Senior Consultant Surgeon in Hepatobiliary Tract, GE Surgery and Liver Transplantation at the Sri Ramakrishna Hospital, Coimbatore. I invite Dr. R. Jayapal Sir to give his lecture.
Good afternoon, everyone, and I thank Dr. Rajesh Babu Sir and other IMA dignitaries and office bearers and the senior people here for giving us this opportunity to present in this forum. And I can see a large number of attendees as well, and thank every one of them to have taken their time off and come for this CME. So today I'll be talking about liver transplantation in India and where do we stand as of now. So as we all know, liver transplantation is indicated for decompensated chronic liver disease patients and decompensated cirrhosis, and the incidence of these diseases are rising exponentially in across the globe as well as in India. And liver transplantation is the only definitive cure for all these end-stage liver disease patients, and we don't have a temporary take care like in kidney failure patients where dialysis can manage these patients for a while. So liver transplantation is the curative treatment for end-stage liver disease, acute liver failure, and many primary liver tumors as well. The aim of this presentation is to critically analyze India's current global position, infrastructure capabilities, ethical dynamics, and systemic bottlenecks, like the rate of disease donations are very poor in India. So we'll be discussing about all these things here. So coming to the indications for transplant, we all know the indications of which in past 2-3 decades earlier, the hepatitis viruses used to be the sole reason for most of the cirrhosis patients, and they contributed a fair share. Whereas with the evolving time, then alcohol liver disease became a significant contributor. In the last decade, we can see a large number of transplants are being done for NASH-related cirrhosis, which is non-alcoholic steatohepatitis, which is recoined now as a metabolic syndrome-associated steatohepatitis and cirrhosis as of today's date. So the NASH, this data is as of 2022 to 23, where you can see NASH cirrhosis and alcoholic liver disease contributing to almost half of the transplants that is happening in India. So the transplant story in India had a uphill journey. India's journey in liver transplantation is a story of a remarkable progress, where it started from a practice shrouded in ethical consent, and it has reached to now a world-class high-volume specialized centers. It was possible due to the inaction of Indian government by implementing the Transplantation of Human Organs Act in 1994, which criminalized the organ trade and paved the legal framework for further organ transplants. So the initial first decade after forming the Transplantation of Human Organs Act was very slow because of the relative inexperience, and the expertise was not huge that time. And in the early 2000s, slowly liver transplant started picking up with the advent of living donor liver transplant programs, and private sectors led the growth. And volume started rapidly increasing in 2020s, and as of 2020, 2010s, and then as of 2022, we can see around 4,000 transplants have been performed in India, with around 200 active transplant centers, with a around 95% success rate for the patients who underwent transplant. So now India stands as a third level as far as the volume is concerned, and it's a global leader in training most of the training surgeons. The increase in the numbers is largely due to the advent of living donor liver transplantation, which we call it as a living donor miracle. In a country like India, where deceased organ donations remain culturally and logistically limited, India has pioneered an excellent solution in the form of living donor liver transplantation, where a single healthy individual can donate a portion of his liver, which regenerates in both the donor as well as the recipient. So you can see the around 3,000 living donor liver transplant procedures were done in 2022, and India stands number one in doing living donor liver transplantation. It contributes to around 80% of the total transplants done. So this is again a snapshot of the data of 2022, where we have around 200 active transplant centers. Now the number has still is even grown further. And in Tamil Nadu alone, we have around 60 transplant centers. So, and again, this chart shows the orange color shows the number of deceased donor liver transplants, and the blue one is the number of living donor liver transplants. You can see from 2014 to 2022, the number of deceased donor transplants has not gone much up. Whereas when you compare here, the living donor liver transplants has gone almost 3 times as compared to the last decade. It again signifies that we need a lot of awareness about deceased donor liver transplants, because deceased donor liver transplants are technically easy. It doesn't put another living donor into an extra surgery, and this will bring the care to everyone and thereby reducing the cost as well. So as of now, the number of total transplants, 85% is being done as living donor transplants, and only 15% we are doing it as a deceased donor transplant. This is because of a low national donation rate, because we have less than 1 donations per million people, whereas in countries like Spain reaches around 50 donations per million people, which is 50 times more as compared to what we are experiencing in India. So to give you a glimpse of how a liver transplant works, I'll show you a few pictures of the actual transplantation. This is how a cirrhotic liver will look like, completely shrunken nodular liver. And this whole cirrhotic liver will be explanted. And now, after removing the complete cirrhotic liver, we can see the inferior vena cava here, and the clamps are applied on the right hepatic vein and middle hepatic veins. So here, now we are seeing this is a portal vein. After removing the liver, the temporary portocaval shunt will be formed to avoid mesenteric venous congestion till we reimplant the new liver. So the initial pictures will be from a deceased donor liver transplants. So this is the retrieved donor organ, and it was now being benched in bench work. What we mean as bench work is we will clear off all the extra fatty tissues and the muscles which are attached to the liver while retrieving the liver from a brain dead person. And this is the portal vein, this is the common hepatic artery, this is the gastroduodenal artery, and this is the left gastric artery. This particular patient also had an additional hepatic artery, which is an arterial anomaly, replaced left hepatic artery. In the bench work, this replaced hepatic artery will be joined with the left gastric artery, and here we will be anastomosing to the recipient's hepatic artery. So this is the liver after implanting, just before reperfusion, where it is preserved in a cold preservative solution, and so it looks very pale, because now the reperfusion means giving back the liver blood flow, which will be happening subsequently. I'm finding it difficult to change slides in this. Is there a issue with this? So this is after reperfusion, where you can see the new liver as a glowing pink organ with a smooth shiny surface. So this is how a whole liver transplantation from a dead donor, which is a deceased donor liver transplantation, looks like. Whereas in living donor liver transplantation, we will split half of the liver from a healthy living donor, and based on recipient's weight, either a right lobe or a left lobe transplantation will be done. So this is the marking of the transection, and this is the end of transection where a liver will be splitted between right and left lobe, and it hangs by only portal vein and artery, which will be divided at the end. So again, this removed right lobe will be benched to reform the middle hepatic vein, and then after reforming the middle hepatic vein, this is how a donor liver, remnant liver will look like after removing the right lobe. This is the IVC. So this is after benching, where this is the right lobe and arterial graft being used for reconstructing the segment 5 and segment 8 vein, which is the new middle hepatic vein for reconstruction. Here again, this is another picture showing autologous vein graft, which is, this is a segment 5 vein, which is joined to this vein graft, and then now the vein graft is also joined to the IHV. So here you can see clearly the right lobe, the autologous vein graft, which is used for middle hepatic vein reconstruction. Now the portal vein is anastomosed and reperfused, the liver is reperfused as well, and the hepatic artery is anastomosed as well. The clamp is applied on the bile duct, which will be anastomosed at the end. This is the IVC, where the new middle hepatic vein and the graft's right hepatic vein will be joined here. So we have a success rate of around 95% for these liver transplantations. We have a success rate of 95% for this liver transplantation. Now, with the increased expertise and a good number of cases, Indian surgeons are mentoring programs globally, and a large number of foreign trainees are now attending Indian transplant centers for learning. And the benchmarks are worldwide benchmarks stand at 95% of patient survival at 1 year, and which currently the Indian data is also shows 95% patient survival. And it underscores our expertise and vast training. So now India is a destination for transplant training, and it is also vastly improved the medical tourism. But the liver transplantation journey is not without any hiccups. There are multiple hard truths and challenges as well. The large number of transplants are being done in private sector, whereas public sector's contribution in doing transplants are relatively less. So going forward, this public sector, strengthening this public sector will help undergo transplants for many low socioeconomic patients who cannot afford a private healthcare. And also, there is a vast deceased donor shortage, and because of the deceased donor shortage, many patients die in the wait list because everyone doesn't have a healthy donor in the family. And only by having more liver donations, by creating awareness, we can meet out this demand benefit and demand supply inadequacy. So as compared to the other states, Tamil Nadu is relatively good at having a good number of branded donations. It's mainly due to the very efficient TRANSTAN system, which is a Transplant Authority of Tamil Nadu, which regulates organ transplants in Tamil Nadu. So when a brain death is identified in a hospital, so clinical information, after clinical confirmation of the brain death disease and counseling with the family, then the particulars of the patient will be notified to the TRANSTAN. And TRANSTAN body acts as a central hub for donor registration and matching. So it has a separate pathway for government hospitals, which does transplants as well, and allocating these patients to the private hospitals in turns. It is a very transparent ethical system, which is helping a large number of patients get transplanted in a safe way. And because of the TNCM health insurance scheme, so the financial part of the transplant is also being taken care of for the needy patients or low socioeconomic group patients who have this card. It acts as a financial safety net. this CM scheme heavily subsidizes and completely covers transplants for eligible low-income families in India. As of now, for liver transplant, the CM scheme provides 22 lakh for the liver transplant, covering up to 2 years of post-transplant care as well. So in most healthy patients, this is sufficient for undergoing transplant as well as having their post-operative care. So as far as now in India, India is a global affordability hub, and medical tourists choose India due to its cost-effective excellence because they can get the transplant done at a much lower cost without compromising the safety, because we have already achieved the benchmark which is seen in other developed countries like US and UK. As of now, the transplant cost of liver transplantation in India is between 15 lakhs and 35 lakhs based on the centers, as compared to the global cost, which exceeds around $3 lakh to $5 lakh. So still, even though India is much cheaper as compared to other countries, it is still prohibitively expensive for low-income domestic population without medical insurance or government aid. Other ethical considerations are also still need to be ironed out because there are a lot of referral kickbacks and fraudulent declarations. There is a gender disparity in donation, with most of the patients as being ironed out in the form of government authorization committees, which is strictly followed in Tamil Nadu. And TRANSTAN body is very transparent, and it creates accountability for all the hospitals involved. So the road ahead for Indian transplant system, liver transplant system, will be to strengthening the public sector as well, whereas the private sector will also continue to grow and enhance transparency, shift the cultural norms, and increase the acceptance of deceased donor donation, as well as increase awareness about deceased donor donation. And this will bridge the demand supply gap. Also, the future horizons will be with the technology and opening the scope in the form of using marginal organs and improving the organ pool, like robotic assisted donor hepatectomies are now on the rise, and this ensures faster donor recovery, and also more donors are accepting this are getting convinced because of the robotic approach. The other thing is, if the particular family doesn't have a suitable donor within them, now government allows for an exchange or a swab transplant between two centers or between two families. This will again increase the number of organ pool for the patient. Can be safely used with the help of normothermic machine perfusion, which will extend the liver viability windows. And to show a glimpse of how a robotic donor hepatectomy is done, I'll be showing a video which of a robotic donor hepatectomy. These are the post-port placements, and this is now we are removing the falciform ligament. And after removing the falciform ligament, liver will be now mobilized from the diaphragm attachments. Now here, right lobe of the liver is being separated off the IVC. So now this is the IVC, and there will be short hepatic veins from the right lobe of the liver to the IVC. Now the short hepatic veins are looped, tied, and clipped and divided. After completely mobilizing the liver of the IVC, now the right hepatic vein is looped with a vessel loop, and a rails tube is also placed for hanging the liver. So the next step will be to separate the right portal vein and right hepatic artery so that this can be clamped and a demarcation line is marked. After the demarcation line is marked, now the liver is being split between the right lobe and left lobe at the Cantley's line. The liver is transected using a QSA probe, which is a Cavitron ultrasonic suction and aspiration device. This removes the liver tissue, leaving only the vessels intact, and those vessels will be seen separate, and this can be clipped and divided. So after splitting the entire liver and dividing the vessels in between, which joins the right lobe and the left lobe, right lobe will be separate. So now the most of the right lobe is separated off the left lobe. And this is the last portion of terminal portion of the division where we are dividing the bile duct. Now, these recent technologies also offer additional information with the help of ICG devices where bile duct can be seen separately with the help of ICG camera. Once the bile duct is divided, now this is the hepatic artery and this is the portal vein. So the hepatic artery and portal vein will be tied and divided, and then finally hepatic vein will be divided. So we are closing the bile duct stump. And then this is how a scar will look like with only a phalansteal cesarean type scar. So with the advent of this technological advancements, more number of takers are coming for living donor liver transplantation as well. So the role in transplant journey will be in early identification of these deceased patients and timely referral for transplant, and we have to debunk myths about organ donation as well as living donor donations. So I would call to action for an early referral with advocate for deceased donations in the community and living donations within the family, and champion equity to help us bridge the gap between demand and the supply. So I would like to thank the attendees and the office bearers of IMA who are present here for giving us this opportunity. And to conclude, I'll say that the only each person's motto should be to enhance the awareness about various organ donations and blood donations, because this is a gift of life where deceased brain dead donor can save up to 7 lives in the community. Thank you, everyone.
Thank you, Dr. Jayapal sir, for giving an excellent lecture about the liver transplantation. At the end of the session, other two speakers, we will have the discussion. So, because there are a lot of questions there in our chat box. Now I invite Dr. S. THIAGARAJAMURTHY sir, the Chief Cardiothoracic Surgeon, Ramakrishna Hospital, to give his talk on ultimate gift, the longevity and long-term realities in heart and lung transplantations. Welcome you, sir. Sir,
Sir, good evening. Good evening, everybody. And thank you, Dr. Rajesh, for giving me this opportunity to give a brief talk about thoracic organ transplantation. And I congratulate you for all the excellent work about the organ donation awareness and also the blood donor camps. And Ramakrishna Hospital has done a great job in this organ pledging. And they have the world record for single day, largest number of people joining for the organ transplantation pledge. And thank you very much. And I'll start the talk now. There is always regarding heart transplantation, there is always a fairy tale imagination by the patients and the general public because of the overhype by the media, and people do not accept the reality. Basically, what they think is once you do the heart transplantation, everything is over and the patient has an excellent lifespan, and then everything goes on normally. Whereas I would like to break some myths on that, and let us see what will happen in the long run after doing a heart and lung transplantation. But before going to that, I would like to tell a bit of history regarding the heart transplantation. It all started with animal experimentation in the 1900s and 50s. And we all know that the Alexis Carrel and Charles Guthrie in the University of Chicago performed the first non-auxiliary heart transplant in the dogs. And they were the ones who perfected the anastomotic techniques. And then Soviets also contributed. Vladimir Demiko has also been mentioned. And then the main research was done in the Stanford University by Norman Shumway and group. But the first human transplant happened in 1967 by Dr. Christian Bernard, who became an international celebrity and went all over the world showing his technique about heart transplantation. But the truth is that it's Norman Shumway group who was in Stanford, and they were the ones who were trying to do it. And they perfected all the animal experiments and everything. They had their entire research under them. Christian Barnard was also observing there, went to South Africa, where the rules and regulations were not there at that particular moment. While the American team was waiting for the rules and regulations to be approved, he went and performed the first human transplant in Groote Hospital in Cape Town. Then Kantrowitz was performed the first pediatric heart transplant. And then the Norman Shumway did the adult heart transplant in 1968. The early human transplants had a very poor outcomes due to body's natural immune response causing fatal rejection, and many centers abandoned the transplant. And then in the 1980s, the immunosuppression revolution happened. The introduction of cyclosporin revolutionized the transplantation, and the immunosuppressive drug prevented the body from rejecting the new heart. And then in 1984, the first successful pediatric heart transplant recipient was Lovett, JP. Even the very young patients could survive with the new medical regimes. With the modern era in the 1990s to till now, innovations of gene mapping, gene expression, microscopy allowed the doctors to continuously monitor the organ rejection. Organ preservation, new techniques were adopted. New cardioplegia methods, new organ preservation solutions were designed, and they gave a longer time for the ischemic time for the organ to be transported and transplanted. And then now we have donation after circulatory death. So in thoracic organ transplantations, heart transplantation is the established standard for end-stage heart failure. It demonstrates the most robust long-term graft survival profiles backed by decades of immunosuppression refinements. Lung transplantation is often performed as a bilateral transplant for severe parenchymal or vascular diseases. It presents a highly complex clinical pathway, very strict immunologic pathways monitoring. Overall, the disease-free and the symptom-free interval is quite short in lung transplantation. Heart and lung transplantation is a rare combined procedure. It is done for Eisenmenger syndrome, where the severe congenital heart disease leads to severe pulmonary hypertension, where removing the heart and only putting a new heart, the new heart will fail because of the very high pulmonary pressures. So globally, the transplant activity, there are only roughly about 5,000 heart transplants are being done. Lung transplants about 4,600, approximately the same number. Heart and lung, very few numbers are being done. So the post-transplant survival, if you look at it, isolated heart transplant, the first year survival is 91%, 5-year survival is 75%, overall median survival is about 10 to 12 years. Isolated lung transplantation is about 85%, 5-year it drops down to 58%, the overall median survival is around 6 years. Combined heart and lung, same, it's because the lung is added to this component, the early 1-year survival, 5-year survival, and the overall median survival is significantly lower compared to the isolated heart transplantation. Well, cardiac post-transplant outcomes. So in the long-term outcome, as I said earlier, because of advancement in calcineurin inhibitor-based immunosuppression, donor organ preservation, early surveillance pushed the median transplant up to 12 years. The recipients surviving the challenging first year usually demonstrate a long survival. So how do you assess and how do you refer a patient to the heart transplant program? So there are many scoring systems, heart failure scoring system. And then this Seattle heart failure model calculates about 1, 2, and 5-year survival rates and life expectancy. It incorporates about 20 variables like patient age, class, NYHA class, ejection fraction, blood pressure, lab values, etc. And there's a transplant threshold is, if by calculating all these methods, if an estimated survival of the patient goes below 80%, 1-year survival, then this patient will be referred for a heart transplantation. So there are many scoring systems like this. This HFSS is also widely used. It stratifies the heart failure patients into low, medium, and high risk groups to establish the 1-year prognosis. It relies on about 7 parameters: heart rate, blood pressure, ejection fraction, retention of sodium levels, ischemic heart disease, presence of heart blocks, and peak VO2 by exercise testing. So the high-risk patients are typically prioritized for transplant due to high 1-year mortality. If the patient has heart failure, low ejection fraction, if their 1-year mortality is 60 to 70%, those are the patients should be ideally referred for elective transplantation. MECI score is a metabolic exercise testing data combined with cardiac and kidney indexes. It highly accurate risk assessment based on both resting and clinical data and exercise tolerance. Transplant threshold is when this MECI score is more than 0.1368 warrants a listing. It's a complex scoring system, though I'm not going to go through that in detail. Low scores are fair. If the patient is having low score, then we can, continue the medical management with these patients. There's another INTERMACS classification. In this classification, this is for emergency heart transplantation for risk stratification. In INTERMACS 1, which is called a crash and burn in short form, there's a high hemodynamic instability in spite of increasing dose of inotropes, patients are inotrope dependent, or the patient may be on ECMO or some other circulatory support. Number 2, INTERMACS number 2 is a sliding on inotropes. IV intravenous inotropic support, but the reasonable blood pressure, but there's a likelihood of rapid deterioration of kidney function, nutritional state, and signs of congestion. INTERMACS 3, dependent stability, hemodynamic stability with low or intermediate but necessary due to hypotension, dose of inotropes, worsening of symptoms. INTERMACS 4 is a frequent flyer. This patient comes and goes out of hospital with symptoms, gets better, goes home. These are INTERMACS 4. INTERMACS 5 is patient is housebound. He cannot go out and do any activity, but at rest at home, he'll be fine. The INTERMACS 6 is a walking wounded. He can walk, but with the only limitation of physical activity. There's no congestion or edema or anything like that, but he is very easily fatigued by even light activity. INTERMACS 7 is a placeholder. Patient in NYHA class 2 or 3, but there is no current or recent unstable episodes. So this is how it is classified, and based on this, the patients are referred, and the severity is assessed, and the organ donor priority is also based on this. So in preoperative assessment, we give an immunological profiling, blood typing, and HLA testing, but HLA testing is not usually done in emergency patients. PRA is done. Exercise testing is done with the echocardiogram, ECG, right heart catheterization and angiogram, and not for is for checked pulmonary function tests, and these ensure that the lungs are enough to handle the new surgery, the new heart. Systemic health and cancer screenings, ultrasound scans and other CT scans are done to rule out any active malignancy. Blood chemistry done for all the liver, renal profiles. Psychosocial screening is also very, very important, and it evaluates the mental health, emotional resilience, and establish a strong support system for the demanding of post-transplant recovery. Patients should not be addicted to any substances and should have adequate family support. Without that, transplant will completely fail for this patient. So now going to the current surgical technique of transplantation. First, the patient is placed on a heart-lung machine, and the recipient heart, the original heart is removed because it will be dilated. Large pericardial cavity will be there. We normally remove it by leaving the cuff of atria and leaving the SVC, IVC, and the aorta and pulmonary artery. Left atrium, the donor heart is prepared, and the donor's left atrium is first sutured to the left atrial cuff along with the pulmonary veins. Then the vena cava is connected, and then finally the great vessels are connected by suturing. And once the suturing is done, the cross clamp is released and the patient's blood is circulated into this donor heart, and then the heart starts beating, and then he will be slowly weaned off the heart-lung machine. These are schematic diagrams to show how the cross clamp is applied, how the SVC and the IVC are divided. SVC and IVC are divided. You have the pulmonary arteries being divided. And then once again, this is another angle showing the superior pulmonary vein and the IVC. So this is the final pulmonary artery being removed. So once this is the empty pericardial cavity of the patient, the new heart is brought in and the left atrial suturing is started on this side. Once the left atrial suturing is done on completely, then only the IVC and the SVC, this is a new technique. And worldwide, this is the technique that is adopted. And then this is how the suture lines look at the end. So this is the flow chart showing the various immunosuppressants that are being used. Now we have the cyclosporin and tacrolimus, which are calcineurin inhibitors. Then we have the sirolimus and everolimus. We have the azathioprine and MFF. And we also have the steroid. These are the 4 drugs that are the mainstay. Commonly started with steroids, azathioprine, and cyclosporin. And then sirolimus and everolimus can be used during the rejection episodes. So this is a global organ transplant volume up to 23. If you look at it, there will be a trend that is a downward trend during the COVID period 2021. Around 4,000 to 5,000 heart transplants are being done, and then slightly lesser lung transplants are being done. So this is another diagram showing since 1982, mostly done in North America and Europe. Other regions contribute very, very less worldwide if you look at it. And since 1982, there's an exponential increase in the heart and lung transplantation. After 90s, it kind of stabilizes. And then there's an organ shortage period. There is less awareness. And then it kind of, every year it is kind of stabilized at the same level. And even in America and Europe, the heart transplant numbers have become pretty much average. And it is not, there is no sudden increase. And that is because of the organ shortage. There are a lot of new research happening with the xenotransplantation, genetically modified pigs. And there are anecdotal survivors of patients up to 1 week or 15 days. The research is ongoing. And once probably if these pig heart transplants, and which is genetically modified pig, which are compatible with humans, then there will be unlimited supply of hearts for transplantation. So now coming to India. India's transplant program is the #1 program in South Asia, with the average heart transplantation rate about 0.2 million population, versus the global average of 1.06 per million population. The deceased donor rate is about 0.67 per million population in India in 2018. The law which made it possible has completed 25 years. In the first 5 years, the law was passed, less than 50 hearts were transplanted. The foundation of deceased donor program was laid through the creation of organ sharing network in the year 2000 by Mohan Foundation, non-governmental organization in Chennai. The role of Health Department of Tamil Nadu in streamlining and disease prevention started in 2008 and 2009, changed the course of the program. Heart transplantation program evolved due to a very handful of committed hospitals from private sector. The challenge was in identification and certification of brain death, and this continues to be the main reason for the low donation rate. Kerala started with the very high numbers initially, and then suddenly the program hit a brick wall where the neurologists refused to sign the brain dead patients. The referral government hospitals, which usually receive traumatic head injuries that result in brain death, but however, they do not have the infrastructure and the financial autonomy or the team to start a transplant program. Hence, the expensive transplant like heart and liver have catered to the needs of the economically affordable class mostly. The total heart donation and transplant activity, global versus India. If you look at it, globally, the green diagram shows very large numbers worldwide, whereas in India, it's very, very small numbers, very low contribution due to all these factors. Coming to lung transplantation, I'll make this brief. Despite the refined surgical protocol, pulmonary grafts are highly sensitive to physiological stresses. Median survival is only about 6 years in adult recipients. This barrier is largely due to chronic lung allograft dysfunction, predominantly presenting as bronchiolitis obliterans, and the patient will remain symptomatic. There used to be a joke when we were training in heart and lung transplantation So the only thing that is different after lung transplantation is that the patient will spit somebody else's sputum. Otherwise, patient will remain symptomatic. So now combined heart and lung, long-term trends, if you look at this 1 year, 5-year horizon, as and when the years pass by, the survival goes down. The long-term causes of death are allograft failure, 35%, infections, cardiovascular causes, malignancies, and other complications. So critical survival risk factors. Patient, he's got a low ejection fraction, he will need a transplantation, or he will go to heart failure and a risk of death within 1 year. So critical survival risk factors. So if the patient prior dependence on ECMO or mechanical ventilation dramatically increases the first year mortality up to 3 to 4 times. So if the patient is on ECMO or balloon pump or are being ventilated, then that patient will be having very high mortality. But if you see, large number of our patients will come only at that stage. Because if you're telling a walking patient who's coming to the clinic, who is in heart failure but managed with medications, but within 1 year he is going to deteriorate. If you tell them that you need a heart transplantation in 6 months or 1 year, those patients usually refuse, or they're in denial phase, and then they go home, and then they come back in a situation where they are in a ventilator stage. And at that time, the finding an organ or maintaining the patient's blood pressure with inotropes, balloon pump, ECMO becomes extremely difficult, and the financial burden is suddenly so high. And then even if you transplant, their mortality is going to be high. That is why in India, many of the centers who started the heart transplant program are not able to sustain it because of the bad publicity that happens after the transplantation because of high mortality. Donor recipient, advanced donor age, and structural size mismatch represent major risk factors for early graft failure. So this is another factor. Suppose if nowadays what is happening is because the availability of organ is very low, they're relaxing the donor criteria. They're trying to get older patients, even with a borderline heart, they're trying to transplant. And those things will increase the survival risk for the patient. Patients with cystic fibrosis, congenital heart achieve significantly higher long-term survival rates compared to restrictive lung diagnosis. And HLA matching drives early onset chronic lung dysfunction and diminishing long-term outcome viability. So if there's a HLA mismatching, there's a lot of problems with lung transplantation. Now, how to increase this longevity? Nowadays, we have this ex vivo organ perfusion, which is a normothermic machine perfusion, which keeps the heart beating on that machine so that it is transported for a longer time, and then you reduce the ischemic time. And this lowers the rate of early graft dysfunction, expands the viable donor pool. And then personalized to advanced diagnosis are incorporated donor-derived cell-free DNA and cell-mediated immunological profiling helps target early subcutaneous rejection methods. So a lot of genetic methods are completely evolving. And I would like to stop here at this moment, because once you go into the further details, that will be too much for our audience right now. So if there's any questions, we can discuss at the end. So I will wait.
Thank you, Dr. Tyagarajan sir, Tyagarajamuthi sir, for your nice lecture. You can stop sharing your slides. Now, I invite Dr. DEEPA Bentley, the Director and Professor, Institute of Anatomy, Madras Medical College, to give the talk on whole body donation.
Thank you for inviting me to be a part of this CME. Whole body donation is a topic on which I'm going to talk about. Whole body donation, as it is a donation of the whole body after death. So all of us, our medical fraternity, we have vivid and lively memories of our first days of anatomy in our dissection halls. So the main purpose of this whole body donation is medical education and scientific research. So with the increase of number of medical colleges and medical seats across the nation, the need for cadavers, the whole bodies, for the purpose of dissection and study by medical undergraduates and postgraduates has increased. So there is a large need. Next slide, please. The need in national level is around 13,000 annually. 13,000 cadavers per year is needed. The National Medical Council Commission mandates the use of one human body to be dissected by 10 medical undergraduate students. So the need, national need is around 12,980 annually, and need for Tamil Nadu alone is about 1,300 per year. So this is an enormous amount. So the need is high and the sources are limited. Also, we have a divide between the government and private medical institutions. According to the law, at present, the private medical institutions, those who are covered under the Anatomy Act of 1951, do not have the license to procure the bodies and embalm. They have to get it only from the government medical institutions, which are governed by the Anatomy Act, and they have the license to procure, embalm, utilize, and transfer it to private medical colleges when they request for it. So there is a huge need, and with the increased social awareness among the people regarding organ donations, etc., there is a concomitant increase in the awareness of whole body donation also. So the people are willing to donate, but the problem is the method of donation, how to approach, and what to do, what are the formalities to be done. All these are black for the public. So our role as physicians is to bridge this gap between the need and the desire of the people to donate. So my talk today will be about how we are doing this bridging of the gap at Madras Medical College, Chennai. Next slide, please. The sources of cadavers are unclaimed bodies which reach our mortuary and donated bodies. But the percentage of cadavers which we get from unclaimed bodies is very minimal. It is only 5 to 10%, whereas the donation bodies procured by donation constitute the bulk. 90 to 95% of the cadavers which we get for an anatomy is through donations. Next slide, please. So as we know, the cadaver is our silent and first teacher, which we keep in memory. All of us need this basic medical science as a building block of whatever career, whatever field we are practicing. Next slide, please. So slightly differing from the other forms of organ donation, a single body is used by medical students, and it forms the basis on which that medical student, after becoming a doctor, is going to treat all the patients he is going to meet in his career. So a single body is going to cater, or it is going to form the basis for treatment of numerous thousands and 10,000s of human lives. So it is very significant. It lights many lamps. So earlier, it used to be the saying that pay attention in anatomy. This is the first and final time you're going to see the cadaver. But not so now. Because even after graduation and becoming a postgraduate, practitioners are surgical practitioners especially, they are coming back to anatomy lab to hone their skills and learn new procedures, endoscopic procedures and robotic surgery procedures, new techniques. All cannot be learned or done straight away on live patients. So they are coming back to our cadaver skill labs to try new procedures. And so we are conducting workshops for postgraduates and practitioners, 4 to 10 workshops every month. So here also there arises a need, apart from the need for training undergraduate students. Next slide, please. What are the requirements for cadaver donation or body donation? Voluntary body donation it is. So there are two types of donations which we receive. Voluntary body donation by the donor who makes a written donation before his death. Even before his death, he expresses his wish that his body be donated to the particular medical college with the consent of his family members. So a sound mind, giving a declaration that he is of a sound mind and with full volition he is donating. Next slide, please. After donation, it is the responsibility of the family members to bring the body and donate it to the particular medical college to which the donation has been registered. At this point, what needs to be stressed that though the patient, the person has donated before death, the nature of death, the cause of death should be a natural cause of death and properly documented medical certificate showing a natural cause of death from a registered medical practitioner is mandatory. Sometimes we have received applications of relatives bringing the body telling though the person has donated before death, but there is an accident or a MLC cause of death has occurred. In such cases, though the donation has been made, we are unable to accept the donations. Next slide, please. Yes. Here we have, as a medical officer, the medical colleges accepting the donation. We have to make sure that the medical certificate of death, which has been issued by the competent authority, is flawless. Next slide, please. We also give them the contact persons, the numbers and the email to which they contact. So once the death occurs, the relatives contact the given numbers and we prepare to receive the patient or the corpse, the body, with due dignity and respect. Next slide, please. The transport and the logistics is the duty of the attenders. However, we can help them by helping them to arrange for the free hearsay service. So this is one type of whole body donation when the donor makes a will or a request and a registration before death. There are some times when the donor expresses the wish to donate his body before the death, but due to unforeseen circumstances, not able to make a registration before death. In that case, the relatives fulfill his wish by donating the body after death. Here also the rules are the same, that we get a written declaration that the deceased has expressed his desire before death. And the documents which we have to collect in both cases, in donation before death and donation after death by the relatives, are proof of identity of the donor of the deceased as well as the relatives, which can be in the form of Aadhaar card, voter ID, or family card, etc. Along with passport size photographs of the deceased, antemortem passport size photographs of the deceased. This is all we need. So the formats are available. We can share it. And such donations are gratefully accepted by medical colleges. We embalm it. And the golden period is 6 to 24 hours. If the family is able to bring the body within 6 to 24 hours, we are able to embalm it. And we have a procedure of embalming, injecting embalming fluid into the arterial system. And after a period of 2 to 4 days, we immerse the body in a immersion fluid for a period of 6 months. Only after 6 months, we are able to take and utilize the body and give it to the students for the purpose of dissection. Next slide. Yes. Thank you for giving me this opportunity.
Sir, on behalf of IMA and the IMA committee and Blood and Organ Donation committee, we thank all the speakers. We really, Rajesh Babu வந்து ஒரு enthusiastic person we have never seen in my IMA life. அதாவது dedicated to the core. ஒவ்வொரு மாசமும் எல்லாரையும் கூட்டிட்டு வந்து நல்லா நான் தமிழ்லேயே பேசுறது சந்தோஷம், நல்லா பேச முடியும். கூட்டிட்டு வந்து எல்லாம் டிஸ்கஷன் பண்ணி அவங்களும் ஸ்பீச் பண்றவங்களும் ரொம்ப இன்ட்ரெஸ்டா நல்லா பண்ணாங்க இன்னைக்கு. அந்த எந்தூசியாசம் அவங்ககிட்ட எந்தூசியம் நமக்கும் வந்து வரணும் அப்படிங்கிறது தான் என்னுடைய ஆசை. ஒவ்வொரு மாசமும் நல்லா நடக்குது. கொஞ்சம் கொஞ்சமா முதல்ல 19 தான் 160 வந்துட்டாங்க. 160,000 ஆகணும் அப்படிங்கிறது தான் என்னுடைய ஆசை. மெம்பர்ஸ் லிசனர்ஸ் பிரசிடென்ட் எலெக்ஷன் நான் ஐ மெம்பர்ஸும் இதை கலந்துக்கிற மாதிரி வைக்கணும் அப்படின்னு சொன்னாரு. அது யார் வேணாலும் கலந்துக்கலாம் மாதிரி அவங்களுக்கு வேணா கேட்கறவங்க நம்ம அனுப்பிச்சுக்கலாம் அந்த லிங்கே. இது வந்து எல்லாரும் கலந்துக்கிற மாதிரி வச்சுக்கோம். மற்றபடி ரொம்ப நல்லா இருந்துச்சு, ரொம்ப சந்தோஷம். எவ்ரி மந்த் we are doing it. The speakers வந்து நெக்ஸ்ட் மந்த் எது இருந்தாலும் you also please join madam, join us. Thank you. Thank you for everybody. Thank you for all the participants. Thank you.
Thank you all, Jayapal sir, THIAGARAJAMURTHY sir, and DEEPA Bentley madam for joining the program, sir. Thank you so much, sir.